Welcome to this online weight loss seminar. I'm Dr. Abbas. The purpose of this seminar is to give you an overview of the trends in obesity over the past several decades, its individual and societal impact, and of course the current treatment options which are available to give patients the best long-term outcomes. The term obesity is frequently used, but what does it mean? What's the definition of obese? Well, obesity is a relative term, and it's when one's weight is considered to be unhealthy to one's height. And the way we calculate that is by calculating something called a BMI, which stands for Body Mass Index. The way you can calculate your body mass index is by weighing yourself in kilograms and dividing that by your height in squared meters. Nowadays, you can go online and type in BMI calculator in your search engine, and you can put in your weight in pounds and your height in feet or inches, and it will automatically convert that and give your BMI. I think it would be a good idea, if you don't already know your BMI, to do that very quickly and then continue on this seminar. So obesity is certainly not a new disease. It used to be thought of disease of the wealthy, and many historical figures struggled with their weights. The table below is meant to give you an idea about what's a normal BMI and what's considered obese. As you can see, a BMI greater than 30 is considered obese. However, we further break down these classes into severe obesity, which is a BMI greater than 35, and morbid obesity, which is a BMI greater than 40. Unfortunately, it's not too infrequent for somebody like myself to see patients with a BMI of 50, 60, 70, even 80 and 90. As your BMI increases, so does your risk of developing obesity-related diseases, such as cardiovascular disease, so hypertension, for example, endocrine disease, diabetes, pulmonary disease, such as sleep apnea, pulmonary hypertension, immunological disorders, musculoskeletal diseases, such as osteoarthritis because of the excess weight and therefore increasing the wear and tear of the hips, knees, ankles, and other joints. And of course, certain malignancies, such as breast, colon, and uterine cancer. And of course, a whole myriad of other diseases as well that are known to be linked to obesity. I want you to follow these graphs now. In the 21st century, there's about 1.8 billion people who are overweight or obese. That number is equal to the number of people who are malnourished and starving. So for the first time in our history, we have an abundance of food and overconsumption of calories. Now I'd like you to follow these graphs which show obesity rates across the United States, starting in the 1980s and ending in 2010. Watch how the graph becomes darker and more intense in color, reflecting the rate of obesity across the states. Observe how we went from a prevalence of about 10%, that's 1 in 10, which in itself is actually quite high, to more than 30% obesity rate in certain states in 2014. So if you imagine a family of 3, a mother, a father, and a child, then one of these 3 will actually be obese. These rates have reached epidemic levels. So nowadays in the United States, more than 1/3 of adults and 17% of youth are obese, and over 15 million Americans are morbidly obese. Obesity is the second most common cause of death from a modifiable behavior risk factor, and that's important, modifiable. In fact, it accounts for more deaths than breast and colon cancers combined. Now, obesity has many effects. It increases the chances of developing comorbidities, increases the risk of disability, impairs one's quality of life, shaves off years off of one's life, and of course significantly increases medical costs. The table below shows a myriad of medical conditions which are associated with obesity, and of course as your weight increases, the risks of developing these conditions increases as well. If you look at these numbers, the medical costs due to obesity is estimated to be between $150 to $210 billion. The cost of caring for people in the emergency room increases exponentially as their BMI increases. The incidence of diabetes has also significantly increased over the past 2 decades. In fact, we think obesity is the major responsible factor for this increase. We think about 75% of hypertensive cases are thought to be attributed to obesity. And this is what new studies are showing, is that 33% of cancer deaths are believed to be directly related to obesity. Now, as one's BMI increases, so does the risk of death. Observe how increasing your BMI is directly related to an increased risk of death in all ages, and that risk increases exponentially. It's not just the quantity of life that is reduced, it's also the quality of life, which is significantly reduced from loss of self-esteem. And of course, when promotions at work are influenced by the way one looks and by one's BMI or weight, then of course it has a direct economic impact for them. Now, there are several factors that obviously play a role in promoting obesity: behavioral, genetic, and environmental. Behavioral, genetic, and environmental factors all play a role in promoting obesity. We are constantly bombarded with fast food ads, which are very affordable, taste good, and cheap, or so you are led to believe. Portion sizes have also increased significantly over the past several decades, and this directly translates into increased caloric consumption per meal, which means it adds to the number of calories we're consuming. And due to environmental factors, which are of course full of easier options, as you can see in this picture, this gentleman has a right intention. He's heading to the gym. However, he would be much better served if he used the stairs. And so decreased caloric burn. And so as we're increasing our caloric intake and decreasing the number of calories that we're burning, we are increasing our weight. Now, some of the genetic factors that also play a role, we can see that mice, which are unable to produce certain hormones, have a high risk of obesity. These mice, for example, they're called the OB negative, are unable to produce leptin, which is a satiety hormone or a feel full hormone. Thus, they never feel full, and so they put on the weight because they do not feel satisfied. I want you to look at this diagram. This diagram shows the new hormones that we've discovered that interact with each other, and essentially it's a balance between two different hormones. Ghrelin, which is produced by specialized cells in the stomach, and it's called the hunger hormone. Whereas leptin, which is produced by fat cells in the body, is the satiety or feel full hormone. Now, both of these have a complex interaction with each other, as well as affecting the neural centers in the brain. This complex interaction between the two leads to the sensation of feeling hungry and therefore needing to consume more calories, or feeling satisfied and therefore limiting the number of calories that you are consuming. Almost all bariatric patients have tried dieting at some point. In fact, some of them have tried multiple diets, and many have even tried medications to aid them with weight loss. So patients have been successful in losing the weight. However, the problem has been rebound weight gain. Once the medications are stopped, it's very common to get the weight that was lost back, and in fact even gain more weight than the starting point pre-dieting. Unfortunately, we haven't found a good medical therapy for successful long-term weight loss results yet. Let's take President Taft as an example. At one point, he was able to lose 60 pounds. However, he gained that back, and he gained even more weight back. So the problem isn't losing weight, but how to keep it off to reap the benefits of long-term weight loss. That made in 1991, the National Institute of Health Consensus Conference on Surgery for Obesity to declare and make this current statement. For patients with morbid obesity who have failed medical therapy, surgical intervention is the only method proven to have a significant, this is a key word, long-term impact on the disease. So what are these surgical therapies? Well, there are three types of bariatric procedures which are most frequently performed in the United States. There is the laparoscopic adjustable gastric band. There's a laparoscopic vertical sleeve gastrectomy. And then we have the laparoscopic Roux-en-Y gastric bypass, which most people just call bypass. The adjustable gastric band has two main components. It has an inflatable balloon, which sits at the junction of the esophagus and the stomach. and it's connected via tubing to a control reservoir, which sits under the skin externally. By injecting fluid in the reservoir, the balloon is inflated and the opening into the stomach from the esophagus is made smaller, thus limiting the amount of food that one can eat and translating into less calories. The second procedure we're going to talk about is the laparoscopic Roux-en-Y gastric bypass. This is the longest studied bariatric procedure, and it consists of creating a 1-ounce gastric pouch. Next, the first portion of the small intestine is divided, and the bottom end of the divided small intestine is brought up to the newly created small stomach pouch. The procedure is completed by connecting the top portion of the divided small bowel to the small intestine further down so that the stomach acid and digestive juices from the bypass stomach and first portion of the small intestine will eventually mix with food. And that's where digestion will occur. The bypass really works by several mechanisms. Firstly, the newly created small pouch allows significantly smaller meals, which translate into less calories consumed. Additionally, because there is less digestion of food now by the smaller stomach pouch, and there is a segment of small intestine which would normally absorb calories as well as nutrients that no longer has food going through it, there's probably to some degree less absorption of calories and nutrients. However, most importantly, rerouting the food produces significant changes in gut hormones that promote satiety, feeling full, therefore suppresses hunger, and reverses one of the primary mechanisms by which obesity induces type 2 diabetes, and it tends to stimulate the pancreas. The last procedure is really a relatively new procedure, and this is the laparoscopic sleeve gastrectomy. In this procedure, about 80% of the stomach is removed, and the remaining stomach resembles a long, thin banana. The gastric sleeve works again by several methods. Firstly, the new stomach will hold considerably less volume, and therefore you'll reduce the amount of food and thus calories that can be consumed. The greater impact, however, seems to be the effect of surgery on, again, gut hormones and the impact of a number of factors, including hunger, satiety, and blood sugar control. There are many myths and misconceptions that are associated with bariatric surgery. I've heard this one quite frequently. Bariatric surgery is very dangerous and should be the last resort therapy. So, bariatric surgery certainly has risks and potential serious complications, but let's put these in perspective. So in 136 scientific reports, which looked at a total of more than 2,000 patients, that's 22,000 patients who had undergone surgery, the mortality quoted was about 0.5%. That's 0.5%. Let me give you a better idea where this stacks up against other common surgical procedures that you may have heard of. So this graph might be a little helpful. The bars on the left of the screen in various shades of blue reflect the mortality rate of bariatric surgery quoted by 4 large papers. The bars on the right sequentially reflect the quoted mortality risk for more of the other common surgical procedures which you may have heard of. The shorter the bar, the lower the risk of mortality. As we can see that the risks of bariatric surgery compare quite favorably with the other frequently performed surgical procedures. The Swedish obesity study, SOS for short, followed about 4,000 patients, half of which underwent surgical therapy and the other half received conventional medical therapy. After 16 years of follow-up, it became quite clear that the mortality, which is the risk of dying, was much lower in the patient population which had undergone surgical therapy. It also showed that the rates of remission and incidence of diabetes, which in itself can have quite serious health sequelae, was also lower in the patient population which underwent surgical therapy. It further demonstrated that patients who had bariatric surgery had a much lower risk of developing fatal cerebrovascular events, such as strokes and, of course, heart attacks. The picture on the left here shows one of my patient's medications pre-bariatric surgery, and the picture on the right is 1 year after bariatric surgery. Of course, not everybody may have these spectacular results. However, in the vast majority of the patient population who undergo bariatric surgical therapy, they will at least take far less medications that they used to take pre-surgery. Or in some instances, they will make spectacular gains and will take no medications, just like this patient did. Let's talk about another misconception. Bariatric surgeries are performed too often. So let's just look at the numbers. Well, we know that there are about 15 million Americans who could potentially benefit from bariatric surgery. And if we look at how many procedures are done on a yearly basis, that's about 175,000, and it's almost plateaued around that number now. This means that we're only meeting the needs of 1% of the eligible patient population. In fact, if anything, we need to reach out to more people and help them to lose the excess weight and get them to be healthier, and so they can reap the benefits of long-term weight loss. Another misconception, which again I hear my patient asking me about, is that the results don't last. You know, we all know of patients who have had bariatric surgery and they've gained the weight back. Well, let's look back at the Swedish obesity subject study group. After 20 years of follow-up, these were the reported results. So you look at this graph now. At the top in blue are patients who only received conventional medical therapy. They didn't lose any weight. The line at the bottom represents patients who underwent gastric bypass surgery. These patients were able to lose more than 25% of their excess body weight and keep it off after 20 years. So the vast majority of people will lose the weight and they will be able to keep the weight off for very long term. There definitely are going to be patients who, for multiple factors, will gain the weight back, and they might even go back to where they started from. So bariatric surgery is a tool. It is not a magic treatment. It's not a magic wand. It will not just make you lose weight and not gain it back if you go back to bad eating habits, bad exercise habits, or you maybe dodge exercise altogether. It's all about calories in and calories burned, and therefore to keeping a balance and of course a healthier lifestyle. The way we can maintain that is by having a multidisciplinary team approach, which is vital for sustained long-term weight loss. And I want to always tell you that you are not alone. Always consult your physician, your primary care doctor, your endocrinologist, your cardiologist, your surgeon, and ask him if you qualify for bariatric weight loss surgery. And also ask him, how can I maintain a healthier lifestyle?